So, in addition, it's going to mandate that all individuals have acceptable health coverage. Those without coverage would pay a penalty of 2.5% of the modified adjusted gross income, up to the cost of the average national premium for self-only or family coverage under a basic plan in the health insurance exchange. And there would be exceptions granted for dependents, religious objections, or financial hardship. And just to give an example for employer requirements, with employer responsible or small businesses or organizations that are trying to provide insurance, it would eliminate or reduce the pay or play assessment for small employers with an annual payroll of less than $400,000. And it has this kind of tiered categorization where certain amounts will be paid for various, 200,000 to 350 or so forth. It will, and this is again all HR 3200. It wants to provide all affordable premium credits to eligible individuals and families with incomes up to 4% federal poverty level to purchase insurance to the health insurance exchange. And it has, again, categorizations for that with, less than 400% to various little tiers again. So it's outlined all of those. One of the things that you probably heard about is this National Health Insurance Exchange. What is that? It's supposed to be a place where individuals and employers can purchase qualified insurance, including from private health plans and a public health insurance option. It would restrict access to coverage through the exchange to individuals who are not enrolled in qualified or grandfathered employer or individual coverage, Medicare, Medicaid, TRICARE, or VA coverage, with some exceptions they have. And it would create a new public health insurance option to be offered through the health insurance exchange that must meet the same requirements as private plans regarding benefit levels, provider networks, consumer protections, and cost sharing. And it would require the public plan to offer basic, enhanced, and premium plans, and permitted to offer premium plus plans. And financing costs of the public plan would go through revenues from premiums. And it has an outline of, like a timeline for how it would do that. And like I said, there's 4 benefit categories that would be offered through that public health insurance option. There'd be a basic plan that it would cover essential benefits package and covers 70% of the benefit costs. Then there's an enhanced plan, which includes essential benefits package and up to 85% benefit costs. A premium plan up to 95% of benefit costs, and then a premium plus plan, which provide premium services such as oral health and vision care as well. HR 3200 would also create a health choices administration to establish the qualifying health benefits standards, establish the exchange, administer the affordability credits, and enforce the requirements for qualified health benefit, including those participating in the exchange or outside the exchange. It would try to simplify health insurance administration by adopting standards for financial and administrative transactions, including timely and transparent claims and denial management processes, and use of standard electronic transactions. And I think another thing that was interesting that a lot of students would like to see is they mentioned this, that they'd like to develop a national strategy to improve the nation's health through evidence-based, clinical, and community-based prevention and wellness activities. We would create task forces on clinical prevention services and community prevention services to develop, update, and disseminate evidence-based recommendations on the use of clinical and community services. This also has a plan to make improvements to the Medicare program. It wants to reform the sustainable growth rate for physicians with incentive payments required drug manufacturers to provide a 50% discount on brand name prescriptions filled in the coverage gap. It would increase the acid test for Medicare Savings Program and Part D low-income subsidies, and it would try to eliminate cost sharing for preventive services in Medicare, and increase Medicare payments for certain preventive services to 100% of the actual charges or fee schedule rate. And especially for a lot of family medicine students and rural medicine students, that HR 3200 has a bit about reforming graduate medical education to increase training of primary care providers by redistributing residency positions and promoting training in outpatient settings and supporting the development of primary care training programs, as well as training health professionals, including advanced education nurses, who will practice in underserved areas. They want to establish a public health workforce corps and promote training of a diverse group of workforce and cultural competence training for healthcare professionals. So, how much is HR 3200 going to cost? The Congressional Budget Office took a look at their plan, and they estimated the net cost of the proposal, minus payments from employers and uninsured individuals, to be $1.042 trillion over the next 10 years. And approximately half the cost of the plan will be financed through savings from Medicare and Medicaid, including incorporating productivity improvements into the Medicare market-based updates, and reducing payments to Medicare Advantage plans, and changing the drug rebate provisions, and reducing potentially preventable hospital readmissions, and cutting Medicaid DSH payments. So that's a little bit about HR 3200, a little bit about President Obama, and I just wanted to read to you a letter, or part of a letter from the Congressional Budget Office to Honorable Michael B. Enzi on the Committee on Health, Education, Labor, and Pensions, and they're talking about the effects of a public plan. And this is what they said. You also asked whether the federally administered public plan that would be offered under the legislation as introduced would have a substantial effect on federal spending for health care. And it goes on to say, first, a public plan as structured in the introduced bill would probably attract a substantial minority of enrollees, in part because it would include a relatively broad network of providers and would be likely to engage in only limited management of its healthcare system, healthcare benefits. As a result, it would add some competitive pressure in many insurance markets that are currently served by a limited number of private insurers. That competitive pressure would probably lower private premiums in the insurance exchanges to a small degree. Second, a public plan is also apt to attract enrollees who overall are less healthy than average, again because it would include a relatively broad network of providers and would probably engage in limited management benefits. Although the payments that all plans the exchanges receive would be adjusted to account for differences in the health of their enrollees, the methods used to make such adjustments are imperfect. As a result, the higher costs of those less healthy enrollees in the public plan would probably be offset partially, but not entirely. The rest of the added costs would have to be reflected in the public plan's premiums. Correspondingly, the costs and premiums of competing private plans would, on average, be slightly lower than if no public plan was available. So again, that was what the Congressional Budget Office wrote to the Committee on Health, Education, Labor, and Pensions. So I hope that's a little bit of the background. You know, we really like you to listen to what each speaker has to say tonight, and then think about some questions you'd like to